morning to everybody all around the world that are following our second virtual roundtable about the CO2RT technique. And let me to very welcome Bruno Freitas from Brazil. Thank you very much, Bruno, to have time to join with us this fantastic roundtable, and thank you for all your contribution. Welcome. And let me also to say thank you to Angiodroid that support both of us during this interesting and educational activity. So the idea of today is to have a small presentation about from Bruno about the CO2 images in endovascular procedures, and finally discuss about the case. During both presentations, there will be some poll questions that from the audience you will be all able to answer, and we finally will discuss about the answers. So thank you again, Bruno, and please start when you want.
Mariano, thank you very much. It's always a pleasure to be with you. You know how much we are friends. It's a pleasure to discuss. It's an honor, actually. Thanks to Angiodroid. Let's talk a little bit very interactively. I would like to stimulate all the colleagues to please make your questions. Mariano can interrupt me at any time. We shall make this a very interactive activity during these difficult times. So one thing I would like to start talking about CIRI, not only about contrast-induced nephropathy or insufficiency, but about impairment, because we will see here that any kind of renal compromise or alteration in the renal function can have very significant consequences. And this will help us also to come up to the point that I would like to state here in this short talk. But a rise of 25%, 0.5 milligrams per deciliter in the basis creatinine of the patient, or also an increase from the baseline in about 25%, will define theoretically the concept of CIRI. Why we believe that CIRI risk is increasing in PAD patients? Because we know that diabetes is an epidemic. We're doing more and more interventions all over the world in more complex older patients and comorbid patients. So we should be always concerned. I would say that renal impairment is part of the package of our patients all over the world. And we know that CIRI is related to very significant rates of morbidity and mortality. And by that, I would namely highlight myocardial infarction and also neurologic stroke, TIA situations. The point is, if we look, sometimes we wait so that the patient can present a severe renal impairment or eventually have a severe decrease in its glomerular function. But as we can see here, small elevations that sometimes we do not take in consideration in the CREA is associated with an elevation, significant elevation of costs as we look up to those patients. So we should be more aware of damaging the kidneys, even though it's a slight damage, I would say. So, and also we have the sensation, some of us, that if we do have some impairment, this is transient, this is fast, and the patient will soon recover. And as we can see here in several publications, we do have an impact not only in hospital mortality, but also after some significant time, like here in those papers after 1 year. We know that in terms of statistic significance, the higher it is, the more important we can see this aspect, but we should recognize patients that have risk factors, take out all the nephrotoxic medication, hydrate our patients, and work with pharmacological strategies, and also minimize as much as we can, or eventually avoid iodine contrast media in many situations if possible. We know that in some departments we also work with the Lasky index. We have an average amount of contrast that we use per procedure. We divide that by the clearance of the patient. If this is higher than 3.7, we really consider as obligatory to look for preventive measurements, even though we're much more liberal in all departments today. We know that we should hydrate. We have guidelines both in the American part, also in the European Society for that is well known. But let's see, if we want to avoid this huge list of measurements to avoid contrast. And we know that some of them just don't work in the real world. For instance, if you need to do an aortogram, if you need to do a iliac cavogram, it will not work with using a small syringe and a small diameter catheter without side hole. You won't be able to find a good image with that. So many of all of those settings here, they are important, but sometimes they just don't work. So I think that using CO2 angiography, it's feasible and a consequent decision in order to minimize the risk of iodine contrast media damage. So why CO2? We have it everywhere in the body stored. We produce it endogenously. It's extensively studied. We know how this is excreted from the lungs, and we have no risk of allergy or contrast-induced renal impairment. It's very soluble. We have a rapid intravascular clearance. It's very ultra low viscose, so we know that it's not dense. So for small vessels, for small bleedings, for distal areas, it works very, very well. Obviously, it does not miss with the blood, so it takes basically the fluid out of the vessel, but it's highly compressible. And by that, I would like to cite first, for the first time, Angiodroid, because since it's an automated device, you can work very properly with different pressure settings, with different volume settings for injection, and also work out with the frames together with your device at home. So we think it's very important for us because it's much more soluble than, for example, the O2, 20 times higher. So, and also very, very cheap. So we know that obviously for us, kidney impairment, acute or chronic, patients that have allergies, problems with the thyroid, also looking for bleedings and leaks, we know these are common indications. But what I would also like to highlight, it's a very cheap and effective method. If we compare acute kidney impairment, comparing CO2 with iodine contrast media, it's impressive how the data favors CO2 in this comparison. If we look specifically to many papers since 98 to our decade, I mean, we have an incidence of CIRI close to zero. And in the casuistics that we have, even though it's low, we know that this has much to do also with the fact that we did not have an automated method by then. It could have too much pressure. You did not control and you didn't have a reproducible way of performing such procedures. They varied widely from center to centers depending on how the procedure was made. Also because there was not established protocol for that. We know that we should not apply more than 100 ml per series. Actually, with Angiodroid, we can work with much lower infusions with very low pressure, and that will even though obtain very good images. We should avoid application upper the diaphragm in the arterial segment, obviously, and we should give a small interval, not longer than 1 minute between series, so that the CO2 can diffuse throughout the lungs. So sometimes you can have a pain, particularly in lower limbs angiography. This is highly diminished as you work with lower volumes, lower pressure, and you can work that out with Angiodroid. There was a huge profit that we took after getting Angiodroid to our department because we were able to manage adequately the setup for those patients. But if they happen and it's really strong, you just lay down the leg a little bit. It'll work quite well, I would say. So you have to be attentive in terms of particularly bigger vessels. You need to be able to take out all the liquids in order to have a good contrastation. This can also be diminished with Angiodroid since you can work up bigger volumes, bigger pressures if possible. Even though we should avoid cranial to the diaphragm to use the CO2, we have been using it a lot, especially in forearm dialysis fistula, central vein stenosis. And if we are sure that there's no atrial or ventricular communication, we can use it very safe. So we do have some side effects, And by that, I would say that all of them can be significantly diminished if you have a reliable, repetitive, systematized way to realize the procedure with CO2 assisted angiograms. And I believe that this device from Angiodroid came up with the possibility of cutting down and slowing about a lot these kind of unwanted side effects. So these were the devices that we used to work with before. As you can see, the proximal images with good technique, they give us quite nice images, but as you go to small vessel below the knee, this is highly complicated as well, also for aortic procedures. So this is the device we are talking about. These are the setups to connect with the catheters. We do have among the machines that we have in our angio suite, a Siemens machine. They have a specific protocol, which is the even flow protocol, which is easily added to your headset in your department. Maybe Mariano will for sure talk a little bit about the packing image sequence that this even flow brings up. But then, as you can see here, we have an automated injector with Angiodroid. We see very good images, both in the aortic iliac segment. We can clearly see the occlusion, the collateralization. And as you compare with this image, we see an increase in terms of quality, but also safetiness as we work with this kind of device, being able with good technique, and this we will discuss a little bit more after the presentation, we can see very good image even in the foot, as we can see here below the knee and below the ankle. But if you do not have a Siemens or a Philips, let's say this is a CR procedure done with a OEC 9900 device, and you see that the quality of the images are quite decent. And here we have a GE Innova angio suite from our department, also with very good images. This is the protocol also for above the knee. Here below the knee angiogram, we can see clearly what are our options even distally without many zooms. So with this, we're trying to come from above. It was not possible. Here I'm doing a retrograde puncture. We're able to use also road mapping and control all the angiogram puncture and insertion of the support catheter. Everything done very clearly with Angiodroid. And this is the final result. So here we have a CR endovascular and EVAR procedure without obviously even full protocol. It's also feasible, possible. Here I just would like to look to show a trapped CO2 bubbles here in the iliac segment. This can be cleaned easily with a little bit of saline solution. You take this bubble out, you continue your procedure if necessary. As comparison here we have iodine and CO2 renal angiograms for procedures. I mean, extremely good quality with good protocol. And we are here with a support catheter, low pressure, low volume, 20 ml, extremely detailed branch vessels from the kidney. As well as EVAR, as I told you, but we have an example of a complex thoracoabdominal aneurysm completely done with CO2. As you guys can see here, you can clearly see the stents. You can work very properly. Very good result. As we compare iodine with carboxy, with CO2, the quality of the images are highly comparable. And here on the left, we do have the catheter on the level of the aorta. Obviously, we lose part of the contrast. So we need to, if we want more quality, here we have a kidney transplant. So we can see clearly not only the main branch artery, but also some polar artery and the details of the kidney circulation, only bringing up the catheter a little bit closer to the site that we want to study and adequate. And we can also set up adequately the Angiodroid device. As you can see here, very clear, good images. So if we see here, it's a very versatile tool. Here we have a patient with a iliac vein thrombosis, iliofemoral deep vein thrombosis. You see here the images on the left. Then we see here a Cockett syndrome after cleaning everything with an Aspirex. And as you can see here, we also treat patients with TIPS procedures done also with a very good quality hepatic artery pseudoaneurysm bleedings, hepatic artery interventions also being done Also, like I told you, central vein stenosis occlusions done with Angiodroid, very good quality. Emergency treatments, endovascular treatments of arterial pseudoaneurysms done completely with Angiodroid. Obviously, we need to watch out for maximal doses. We will talk a little bit about that. Never more than 100 ml. Rarely needed, I would say, but I would love to listen to Mariano's opinion. And in order to optimize, obviously you need DSA. Obviously, you need the patient not to move. Use and hold catheters. Place the catheters closely to the artery as possible, so that with these two options you can diminish the number of bubbles. Slow pressure injection, it's very important. You sometimes, depending on the vessel, you need to rotate the device in order to see adequately the vessel, like in the renal artery, for instance. As you can see here, like I showed in the previous example, we need to bring closer the catheter to the region. We could almost see, not see the internal iliac vessel, but by adjusting not only the pressure, the volume, but also bringing the catheter close to the internal iliac, we could study it adequately in order to embolize the patient. We should give also a little bit of time, like I told you, 1 minute. If we have an overdose, which is absolutely difficult to have with Angiodroid, because you control how much you're infusing, you can just turn the patient to the left side position. And as I told you, you can lay down the legs if necessary. So why do we need to consider as a world community CO2 angio? Because CIRI is a reality, much more common, much more frequent than in 2 decades ago. We should also avoid allergic response to iodine catheter. It has a very good contrast with very low viscosity. You can image also via smaller bore, longer catheters, and also the costs. Not only the direct costs of the contrast itself, but also indirect costs that are also very important in terms of hospital stays, lung impairment, comorbidities, dialysis, etc. So we believe that using this device provides a very reliable, constant, systematized injection that you can adapt to the patient, to the region, to the systolic blood. And in devices that have the even flow protocol, it also results in a better image because it reduces the bubble gas and enhances the quality of the images. And by that, I would say that this device, and specifically regarding CO2 angiography, changed a lot my practice, because if I want to use CO2, I don't need any pre-admissional assays for renal insufficiency. Second, I don't need any pre-medications for allergy. This is not an issue for me. So, and this has increased the number of patients that I consider treating, because in some patients very kidney ill, I sometimes avoid or postpone the treatment because of concerns of renal impairment. If I'm more liberal in the use of CO2, I can treat more patients on a more liberal manner. And by that, I would like to end that this current technology, as I could show, is able to allow us to treat patients with zero contrast. This is not a myth anymore, unless we consider a more liberal use of CO2. I hope that was not much long. I just wanted to show how the possibilities are wide, and we have to consider a lot of particularities when working with this technology. Thank you very much, Mariano.
Oh, thank you, Bruno. Thank you very much. More or less always, I fully agree with you and everything you said. Fantastic cases. Just to summarize, you show that CO2 today is fully available and can be used for every vascular segment. I have a question for you. How often do you see or did you see in the past side effect? Because you list a multiple side effects from CO2. And I remember when I start Luca from Angelo saying, yeah, it can happen. Honestly speaking, I never saw a side effect from CO2. If we consider pain, this is the only side effect. If we consider pain like a side effect, this is the only side effect that I see, but there were any other. What is your experience about that?
Okay, so I did see some, extremely rare, as you said, but I must say that me and also many people that I worked with, and by that I would namely mention the guys from Leipzig, we are very liberal in the use of CO2. Indeed, we did not use only Angiodroid, specifically in the beginning of our experience. We used a lot of CO2 devices, sometimes no device, only a tube and a syringe, 50 ml, 60 ml syringe, and tried to do the best that we could. And I did some micro arterioembolizations in patients and thrombotic embolizations as we were treating acute mesenteric ischemia only purely with CO2. This was a very severe patient, fat, obese, diabetic, with a critical level of renal impairment, and we did everything with a syringe CO2, and we had an arterioembolization, arterioembolic embolization. We had to take it out with aspiration. I did see some problems after EVER, but also not with Angiodroid, because we probably pressured too much with the syringe, repetitive volumes, and we did have embolizations to the visceral arteries that we could only see 2 days afterwards. But the vast majority of patients, it's pain, which is extremely diminished with Angiodroid and good technique, because if you have Angiodroid, but you go with 80 ml of injection, 350 psi with Angiodroid setting, to make an angiogram in the anterior tibial, you will have problems. So the Angiodroid is good because you can set up everything on a very reliable, repetitive manner. So you stay on the safe side. You avoid depending on your hand, your syringe, whatever you want, but you have a machine that does the work for you. So pain is by far the most frequent symptom that we see, normally the only one, but it's highly diminished as we started using the Angiodroid with a good technique and setup.
Perfect. Thank you so much. So maybe we can see the result of the first poll question. How do you treat patients with high creatinine level? 71% today answer that they use CO2. So it means that most of us believe in the CO2 like a use for a high level creatinine. There are a couple of other questions that I want to share with you, Bruno. One question, I think you answered it during your presentation, which CO2 software package Siemens EF Philips is optimal for CO2 angio. I believe every software from every manufacturer is adequate, it's good for CO2. How many frames? 5, 7 frames. I usually use 3 frames per second, and below the knee in the legs, it is enough. I don't know if you have a different experience.
Well, the point is, as we work with Siemens, my friend, working with the low frame per second, 3, 4, is okay, because as you know, it packs the images and enhances the quality, particularly with the BV Philips ARC and also with the OEC. I would recommend to increase a little bit the frames closer to 6 or 7, because then you would make a artificial packing of images by doing more frames per second. So the quality of your image would enhance. There is no need and no indications to do that with the Siemens package, because we have the even flow, and also with the Allura and newer devices. I don't know where are the guys all over the world, but from the Allura, Integris Allura, to the newer devices from Philips, you also can work with lower frames without no problem.
In fact, this is my experience. I use 3 frames per second and I obtain a very good result. The other question was, do you use any specific patient setup during the CO2 angiography in BTK investigation? Turn the lemur in 40%, 38%, pharmacological preparation in 23%, no specific setup in 38%. So 1/3, 1/3, and 1/3. Honestly speaking, in most of my cases, I don't need any specific setup. Turn the lemur, as multiple times we discussed, we start to do it, and finally we realize that we don't need it. We can manage with images without elevate the legs. About the pharmacological support, the time you reduce the volume, the time you reduce the pressure injection, like you perfectly explained, Bruno, you reduce the pain, so you don't need any pharmacological support in most of the patients. And with most of the patients, I mean 85% of the patients, you can obtain adequate images, adequate angiographic images without any specific patient preparation.
One thing I would like to highlight, I mean, I have never had the need to use, for instance, glucagon in any patient. And honestly, I have never seen personally anyone who has used it. It is described here or there. Someone mentions like a talk that someone used, but I have never met anyone heavy user and also with Angiodroid. Never. I don't know if you have used. I've never.
Never, never. The same experience than you. Exactly the same. I never use. Honestly speaking, I don't have too much experience doing aortic or aortoiliac disease with CO2. I usually work anticoagulate going down to the foot, but I never use glucagon or any other bowel preparation. Another question, what anesthesia do you usually use? I work in a local anesthesia, so no any sedation, no any type of pharmacological preparation for my patients.
I was comparing the amount of regional or eventually deep sedation anesthesia for CO2 patients because I'm preparing a publication. I was comparing our patients from here, from the German ones. And to be honest, I significantly have to use more deep sedation or sometimes blockage because I should avoid patients to move. And I cannot explain that, but maybe the German patients are more disciplined. I don't know. And I face difficulties, especially in more long procedures, to be able to make the patient stay. So if the patient is very anxious, if the patient is very moving too much, then I would rather go for a more appropriate anesthesia. And to be honest, my last two life cases, I was afraid that the patient was going to move in front of everybody, and I asked the guys to go for a more different anesthesia. But on the regular way, I go regular case. I would go with local anesthesia only.
Well, yeah, it happens sometimes with the live cases. There is another question directly for you, Bruno. When you have to do a complex aortic procedure, do you prefer to inject into the visceral vessels from within them with an introducer and selective injection, or from the aorta with the volume of the aorta and pointing toward the visceral vessels?
Okay,
so you prefer to use super selective or from the aorta?
Okay, for regular infrarenal EVER, I would just do as we do in the beginning. I tried to be selective. I tried to protect to the guide wire. I was a little bit worried about safe, if it was safe or not. So now I work with an end hole catheter. I love to work with a mammary catheter, or with if I'm working with a centigrated catheter, a straight one, and I keep it through the other side above the aorta, and I rarely do the controls out of that for an infrarenal. Okay, if I need to go for previous internal iliac embolization, if I need to select and do thoraco-abdominal, then I would do the visceral vessels more selectively, and I could rather do it through a normal catheter or preferably through a support catheter. The images are very, very good. I mean, we have a little bit more difficulties if you're doing not branched procedures, but fenestrated. If you're working with fenestrated, then it's better to pass with a normal catheter, a mammaria, whatever, and do the angiogram through the catheter, because you will need a little bit bigger volumes in order to not only fill the sac, but fulfill all the vessel adequately.
Okay, the last 2 or 3 questions. How you seem to decrease the cost to use the department science increasing CO2 use? I have been discussing with Sebastiano 1 hour ago I checked in Abanoterme last year, and we reduced 65% the cost of use contrast medium compared to the period in which we have been combining both. So 65% less cost. Anna from Argentina asked if I use CO2 in all diabetic patients, including those patients without renal insufficiency. Yes, I use CO2 for every patient. I puncture the patient, put the 6 French sheath, connect the Angiodroid injector to the side arm of the sheath, and do a diagnostic angiography with CO2 in all my patients. It's more or less like you said. I don't take care about the allergy or the pre-medication for allergic reaction to the iodium. It's the same for me. I don't take care too much about the creatinine because I need that at the end of the day, I will try to do as much as possible with CO2. So why consider CO2 angiography? As I said, I use CO2 for every diabetic patient with CLI for diagnostic evaluation of every CLI patient. We have a standard protocol, and I'm going to answer a previous question. My protocol is 20 cc or millimeters of CO2 injected at the pressure of 120 millimeters of mercury. So it's a standard protocol that I use for the legs, injecting through the groin, and also in many of the cases in which I do a super selective injection, as Bruno showed. If we set up properly the pressure and the volume, we can obtain fantastic images. And so using this protocol, we know we can do a lower limits diagnostic angiography. I will show a case. This is a case of a couple of weeks ago. Antegrade access the common femoral, put a 6 French sheath. As you can see, the patient has a diseased common femoral, small common femoral, and big superficial femoral artery. You can see how CO2 performed, no bubbles, with this volume and this pressure, perfect injection that filled a little bit up the common and the external iliac, the profunda and the SFA, and this patient did a thrombus endarterectomy, a remote thrombus endarterectomy of the whole SFA. That's the reason why this SFA is so big. And you can see there is a gap in the passage between the SFA and the POP, but still having healthy common femoral and healthy popliteal artery. But again, extreme case, the patient that was already revascularized from the surgical point of view without any treatment in below the knee. So I was able to evaluate properly the SFA and the POP. It seems a bypass, but it is not. And through this sheet, I was also able to see how the CO2 advance and arrive in the tibial segment. And after the injection with the proper reconstruction, with the proper stacking, summatory, and the pixel shift, and so on, we were able to identify peroneal artery patent, occlusion of the anterior and posterior tibial, and with the same protocol, with the same type of injection through the groin, we were also able to identify all the foot arteries. We were able to identify the peroneal arriving at the ankle level, the perforant branches, and that was very easy to depict and to clearly identify also the dorsalis pedis. So after this diagnostic angio, some precise indication, answering again to the previous question, I have been talking about the necessity of a good processing of the images with the stacking, masking, summatory of all the frames, and so on, that it allows us to finally have a full field vessel in the images. But I was also discussing about the necessity to follow a protocol in which a standard injection and the standard pressure and standard volume allow us to clearly identify all the vascular images. The only cases in which we move forward with a super selective injection could be cases like the case I show, in which we have a healthy SFA and POP. So just to reduce the volume of the injection and just to reduce the pain, we move forward with a super selective injection in the below the knee segment. continues to the previous cases, I will show you the intervention and the final result, because it's important to realize that what we see, what we saw with CO2 is the real situation. So at that point, using a 4 French catheter and a V18 guide wire and O18, I was able to engage the anterior tibial, and look, it was not so easy to go down, so I need to manage this long CTO to reach the dorsalis pedis. But in the dorsalis pedis, I was clearly navigating. So the foot artery, the dorsalis pedis, and the arch were patterned as CO2 showed me. So following these images, I was able to cross the anterior tibial, dilate all the anterior tibial at 3 millimeters, and through the arch, I was able to retrogradely recanalize the lateral plantar. I pre-dilate with a short and small balloon. This is a 2 millimeter balloon, the lateral plantar artery, increasing the diameter of the distal PT to be able to re-enter suddenly after antegrade recanalization also of the posterior tibial. And again, it is the proof that the posterior tibial was fully occluded, but I was able to recanalize it retrogradely, and finally I pass a second guide wire antegrade to finish the job. And again, you will see that even if I was able to suddenly engage the posterior tibial, there was some difficulties to cross it with the V18. In fact, I did it in a loop-shaped tip in the subintimal way, but finally was able to connect the antegrade and retrograde guide wires, dilate also all the posterior tibial and the plantar artery, and I was able to do all the controls with the CO2 that I'm going to show you rapidly. And this is what I was able to obtain with direct blood flow in the anterior and in the posterior tibial, and also maintaining the flow in the peroneal artery. And also I was able to obtain a very nice images of the foot with direct blood flow in the dorsalis pedis and in the plantar arteries. And you can see after the proper images reconstruction, I was able to obtain clear images of all the foot arteries with the CO2. So this is a clear case, like Bruno said before, of zero contrast case in which I never need to use iodinated contrast medium. So as a take-home message again, in our perspective, because I believe I'm speaking about me and Bruno too, the CO2 as a daily practice, we use CO2 in many vascular territories, also in veins, and we use it all the days, every day. The post-processing technique, this is some point that need to pay attention, because after many years, I used to see the CO2 running and to identify the vascular structures, but when you need to be precise, you need someone processing your images. And finally, consider that CO2 doesn't want to substitute the iodinated contrast medium, but everyone propose it as a complementary approach, but for sure, in many of diabetic patients that we treat every day, we can reduce for sure, and in some cases avoid the use of iodinated contrast medium.
One question I would like to state: if you have any issues regarding CO2 injection in chronic COPD patients.
Well, this is a good question. In the last 6 years that I have been using CO2, there was only one case, and it was a live case with a patient with lung compromisation that we decide, before to start the procedure, we decide to avoid the CO2 because it could create some breath problems. But honestly speaking, again, it's like creatinine. I never take care about lung problems. I mean, it's never happened for me to have any respiratory compromisation or problem related to CO2.
Especially because the time so that the CO2 can diffuse and be extracted, it's extremely fast. And in COPD patient, you even have more CO2 in the tissues than in a normal patient. And those are CO2 let's say, resistant patients, I would say. So another question that is made is what kind of pressure and volume parameters you suggest in order to reduce lower limb distal pain during CO2 with Angiodroid, and if you work with elevated legs, when do you elevate your legs and for how long you do it?
Well, I have been answering this question during the presentation, during the case. I mean, my protocol is 20 cc's of CO2 at 120 millimeters of mercury of pressure. This is my standard protocol. In some cases, I change it. For example, patients that have a patent SFA and POP, I put the full French catheter in the P3 segment to continue super selectively and usually reduce the volume to 10 cc's of CO2, or some other patients in which they could have some very severe compromise runoff. So in that patients, sometimes I increase a little bit the pressure till 150 millimeters of mercury, or the other trick is to elevate the legs, but no frequently I use the trundle lumbar. I can't remember the last time I elevate the legs to the patient.
Dr. Perez, he's asking us how can he pack his images because he has a Siemens device. This is not necessary to pack. We were describing that there is a setup, a CO2 specific setup in the Siemens machines, that if it is not in your machine, you can actualize, do a warm-up by internet. It's easy. It doesn't take more than 20 minutes. And then it's in your machine. You just set up, click on it, and it will work. And the packing is done automatically. We were just describing, me and Mariano, that the image quality is better, that they take out the bubbles, but this is already automatically made. Once you have a Siemens device, you just download the package if it is not already in your device, and you use it. That's it.
The answer of the previous pool question, when do you recommend it to use the CO2 angiography procedures? Only 30% of our colleagues answer like CO2 as a first choice. Unfortunately, it allowed me to understand that still need to be more convinced to the audience, or we need just to share more experience, because honestly speaking, when I started to work with the CO2, I was not fully convinced, but step by step, I was able to understand that this is a very futuristic tool, because we can do the same with a better result in terms of less seeing, less renal insufficiency or renal compromisation without lose anything. We can obtain all the information we really need, but we can be better, more clinical with our patients, reducing the risk of renal insufficiency.
Mariano, just this pool that you just analyzed now brings up a question of our friend that you know very well, Dr. Ana Molon from Argentina. She's asking us, particularly would like to have your answer, whether you use CO2 in all diabetic patients, including those without renal insufficiency. And I would just try to add something to her question if I could. If you are more liberal in the use of CO2, why?
Why? As I said before, I started 5-6 years ago to work with the first prototype of Angiodroid, and I finally realized that I was able to obtain excellent images. So why not? If you know today that with the CO2 you can avoid any renal insufficiency, any renal compromisation, I work every day with diabetic patients with CLI, so the baseline clinical conditions are worse, are very, very bad in all the patients. So why not to try to avoid any other problem? No liquids, no iodium, why not?
So there, I mean, this term does not exist. So probably, I hope nobody sues me for that. But if I could say, we do have some patients that are renal susceptible patients. So we have the renal impaired patients. We have patients that already have some kind of disease, and we have patients that can have an involvement because of an intervention. So one of the principles in medicine is not to harm our patients. When I did not have a technology that could bring me a good image, that could bring me good confidence, that was not reliable, systematic, then I would go for the one which would bring me better images, and I would be sure where I was supposed to do. With good quality images from automated CO2 angiography and good technique, the images are highly comparable in a huge amount of patients. Okay, costs are an issue. So in Europe, cost the business is different than in Brazil. So probably the more liberal use of CO2 favors the use more in Italy than here in Brazil. But I'm pretty sure that things are changing, and probably here in Brazil we'll be closer than you in Italy from the business part of the market. And it's safe and it's repetitive. And this is why I think that your approach, using it very liberal, not only in kidney impaired patients, but also in susceptible patients, it makes a lot of sense.
Yeah, and another thing that make a lot of sense is the time you start to use it is the time you start to understand it, the time you start to believe in it, and the time you finally start to realize that it's a very good tool comparable to the iodinated contrast medium, so you can type send information, avoiding some risk for the patient and earning money. Because the time Dr. Manzi and me did a check between the expenses of iodium alone or both contrast medium together, and our administration bought the Angiodroid machine. So I mean, we were going to earn 65% of money.
Oh, one short question. I know that you don't do many aortic procedures, but not it's not your major procedure. But I do a lot of aortic procedures. We do venous procedures a lot. The volumes of contrast sometimes are high. Those patients are old patients. Those patients are ill patients. It's not uncommon that we say, okay, I'm not sure about it, but I don't want to do another shot because I don't want to. I already did pretty much contrast. This is absolutely not an issue with CO2. So I'm not worried
Exactly.
about how many shots I did. If I gave time to the device, to the CO2 to be worked by the lungs, I can do as many injections as I wish. This is not an issue in terms of volume because the patient is a cardiac insufficient patient. This is not a worry for me. I'm not worried because we are focused too much, and it's important on the kidneys because the classical indication for CO2 was kidney impairment. But times are evolving. We are treating more and more ill patients. Sometimes volume is a problem. You have chronic cardiac congestive patients, classification 3 and 4. You cannot do as much volume as you want. You have pulmonary hypertensive patients. You cannot do as much as you want. You have also allergy issues. So, on the point of view, the quality of the image is good. The quality of it's reliable. I think that the more liberal use should be something we should try on. There is a learning curve, yes, there is, but once you get used to it, which is fast, I think it's highly reasonable.
Yeah, absolutely agree. The learning curve is not so long. It's like to learn how to make a ultrasound guided access. I mean, the time you repeat it for 1 week, and finally you understand the process, and you are able to start to do it for yourself. So it's the same with CO2. The first time seeing black and white or white and black, the change of the contrast can create some confusion. But the time you start to do and to repeat that, you realize that you're able to understand and you are able to
Oh,
obtain the same images.
Dr. Mahmoud Tolba is just reminding us that we do have CIRI. Also, in some patients, we have preoperative normal levels of creatinine. So we're not certain that we will not have CIRI by having a preoperative normal CREA level.
About the CIRI, this was another thing that pushed us forward to use a lot of CO2, because we realized that after 2 years, 35% of our population, of our diabetic foot population, finish in dialysis. And we cannot realize if it is related to multiple repeated procedures to save the limb, or if it was the natural history of that patient. But even when you have a normal creatinine level, the patient is at risk. I want to say, Bruno, thank you so much. You are a big friend, and as always, I enjoy too much this discussion, this friendly and interactive discussion. I want to say thank you so much to every one of the participants and the audience, and thank you again to Angiodroid guys and to Sebastiano to support us in this educational activity.
Bye-bye, Mariano. Bye-bye. All stay safe. Thanks, Angiodroid. Thanks to all the guys. Be safe. Stay at home. Bye-bye.